Hello again. This is Dr. Wiam, Senior Consultant Endocrinologist from Bahrain. Again, it gives me great pleasure to welcome you all to the Adult Clinical Practice Symposium in Adrenal and Pituitary. Before we start, I'd like to urge you all to visit the exhibition and visit our sponsors booth and abstract room as well. And please remember, if you are not a member of the association, this year we are giving a free membership to all, so try to utilize this free membership. Today, we will cover very important clinical topics, 2 adrenal and 2 pituitary, and we have for you 4 internationally renowned speakers lined up for you from United Arab Emirates, Saudi Arabia, and all the way to Rochester, Minnesota. Finally, it truly gives me a great privilege to co-chair the session with Dr. Hussein Saadi. He is the chair of the Medical Subspecialties Institute of Cleveland Clinic, Abu Dhabi, and he's also a clinical professor at the Cleveland Clinic Lerner College of Medicine of Case Western Reserve University and a professor at Khalifa University. I met Dr. Hussein and worked with him almost 26 years ago in Cleveland Clinic during my first fellowship, and it's really nice to have him with us. With that, I'd like to hand over to Dr. Hussein. Abu Fadl.
Thank you, Dr. Wiam, for the kind introduction. It's my pleasure to be co-chairing this great session with him. And we have eminent speakers, of course, Professor William Young, who's currently the Tyson Family Endocrinology Professor of Medicine at Mayo Clinic. He's well known to most of you, having delivered more than 650 lectures, international and national, at more than 150 institutions across the globe. He's well known to everyone, and we are really delighted to have him with us today to talk about a very common topic, glucocorticoid withdrawal tips and tricks. Professor Young, please go ahead.
Thank you, Dr. Saadi, for that kind introduction. So with regard to this topic, I've come up with an approach over the years with regard to this problem. It's an issue in our patients who have endogenous Cushing syndrome, and we've cured them, and now they need to recover. But more commonly, it's an issue with patients who are placed on glucocorticoids, and eventually it's discovered that they probably don't need them. They probably didn't have that underlying diagnosis that they were initially placed on glucocorticoids for. With regard to this presentation, no relevant financial relationships to disclose, no off-label drug usage. So the outline for my presentation is shown in this slide. I'll review the Mayo Clinic approach to monitoring the recovery of the hypothalamic pituitary adrenal axis after resolution of Cushing syndrome, whether endogenous or exogenous. And along the way, I'll share some tips for success. So this is my 23 rule. So 20 milligrams in 3-week rule. So it's likely that the HPA axis is suppressed if the glucocorticoid dose has been 20 milligrams of prednisone or the equivalent every day for 3 weeks or more. Or the patient's been on a bedtime dose of prednisone, 5 milligrams or equivalent, for more than 3 weeks. HPA axis suppression is possible and more likely the higher the dose if the dosage of prednisone is 5 to 20 milligrams a day for more than 3 weeks. And finally, HPA axis is unlikely, but it could still happen if there's any glucocorticoid dose given for less than 3 weeks, or if the patient's on alternate day prednisone that's less than 10 milligrams every other day. So that's the background of what causes iatrogenic suppression of the HPA axis. And I mentioned prednisone or its equivalent. So this is the glucocorticoid equivalency table that we all learned in medical school. You can see prednisone here in the top middle. 5 milligrams is equivalent to 20 of hydrocortisone and is equivalent to 0.75 milligrams dexamethasone. So how should we test the HPA axis recovery after it's been suppressed by endogenous or exogenous corticosteroids? And I have a hint. I personally have not ordered a concentropin stimulation test for this purpose in more than 2 decades. So we published our approach to this problem a couple years ago now in Clinical Endocrinology. We published this retrospective study of 81 patients with subclinical Cushing's or moderate to severe adrenal dependent Cushing's who developed adrenal insufficiency after unilateral adrenalectomy. The recovery of the hypothalamic pituitary adrenal axis occurred at a median of 4.3 months after adrenalectomy. However, the more severe the Cushing's, the longer it took to recover. So for severe Cushing's, almost a year. For moderate Cushing's, almost 3 months. And for subclinical Cushing's, about 2 months. The main predictors of that recovery interval, how long it took to recover, included what was the result of the 1 milligram overnight DEX suppression test prior to surgery. If the serum cortisol was higher than 10 microgram per DL, it took longer, an average of 9.7 months. Whereas if it was less than 10, it was the average of 1.3 months. Duration of symptoms. If it was more than a year prior to being diagnosed with Cushing's or subclinical Cushing's, then it took almost a year to recover, whereas if it was less than a year for symptoms, about 3 months. The presence of moon phases, in other words, physical stigmata of Cushing's. If they're present, it took longer. If they were absent, it took shorter. If there was myopathy present, again, it took a little over a year versus about 3 months if no myopathy. None of these should be surprises. It basically reflects the more severe the Cushing's, the longer the Cushing's, the longer it's going to take for the HPA axis to recover. Glucocorticoid withdrawal symptoms were observed in all the groups, whether the patient had severe Cushing's, moderate Cushing's, or subclinical Cushing's. But what proved to be controversial during the peer review process was how we monitored the recovery of the HPA axis. Indeed, it appeared this paper was not going to get published. We had a conversation with the editor and challenged a couple of the main issues brought up by reviewers. One of them was that we didn't follow the endocrine society guidelines. Why is that? I'm going to show you our approach to glucocorticoid taper and monitoring the recovery of the axis. So let's say the patient has typical Cushing's and we've cured them with surgery, whether it's pituitary adrenal dependent. Typical dose they go home on a prednisone is 10 and 5. There's 4 times in a day when you give steroids: breakfast, noontime, evening mealtime, bedtime. So that's what that means: 10, 0, 5, 0. 10 in the morning, none at noon, 5 at evening mealtime, none at bedtime. If the patient has ectopic, more severe Cushing's, we may send them home on an even higher dose. Then we drop that dose by 2.5 milligrams every 2 weeks. So it goes 7.5, 5, 5 and 5, 5 and 2.5. Once we get to 5 and 2.5, we substitute a shorter acting glucocorticoid, hydrocortisone, with an equivalent dose, 20 and 10. Then we drop that dose by 5 milligrams every 2 weeks. So 15 and 10, 15 and 5, and then just 15 in the morning, and we keep it there. No more taper. We simply check a morning cortisol before they take their morning dose of hydrocortisone every 6 weeks. When the morning cortisol is above 10, the HPA axis has recovered, we stop hydrocortisone. So that's our approach to monitoring the HPA axis after it's been suppressed with either exogenous or endogenous cortisol. So to get this paper in the literature, we had to make this point that this represented our extensive clinical experience and that we did not follow the endocrine society guidelines. The argument we made is everyone always followed all the guidelines. How is we ever going to have innovations? It's really a roadblock to progress. And the third thing we agreed to was to have a commentary published with the article. And here's the commentary by Seajor and Murray. And it was actually quite positive. Hurtado et al. Have described a clinically sensible approach to the management of potential adrenal insufficiency following unilateral adrenalectomy for autonomous glucocorticoid secretion. This approach is safe and avoids dependence on repeated stimulation tests of the HP axis. Many endocrinologists would, however, find it preferable to confirm a normal HP axis with a stimulated test once recovery of the axis is suggested by the ADM cortisol. So the key message of this article was simply check a morning cortisol before the patient takes their morning dose of hydrocortisone to monitor for recovery. By measuring cortisol from the adrenal, you're determining how well the hypothalamus is making CRH, you're determining how well the pituitary is making ACTH, and you're determining how well the adrenal gland is making cortisol. It's testing the whole axis. Whereas a cosentropin stimulation test is just testing the adrenal glands. And that, to be honest, that's not what I'm worried about. The adrenal will always wake up. I'm worried about the hypothalamus and pituitary. When the morning cortisol is above 10, the axis has recovered. And there's no need, absolutely no need, for cosentropin stim tests. So, tips for success in this process. It's all about patient education. So we have a patient education guide. It's several pages. You've been taking a high dose of cortisone-like medication. We designed this primarily for exogenous Cushing syndrome because that's actually the most common scenario faced by endocrinologists. Your physician has decided you don't need to take the steroid medication long-term to treat your disorder. And this is information is provided to slowly taper your high dose. And we address several key points in this education guide. One is it's going to take many weeks or months to taper off, and why they can't just stop a glucocorticoid, and why their dose was high to begin with. And finally, at the bottom there, if your dose of medicine is lowered too quickly, you will get very sick. And this is a really important point. Everyone who tapers off steroid meds goes through withdrawal. And this includes having flu-like symptoms, muscle aches, nausea. Going through this stage is common and necessary side effect of tapering your medication. If you feel so bad that you're curled up in bed, you can't go to work or school, your care team will need to slow your taper or change your dosage. Everyone has withdrawal symptoms, but the goal is to reduce your medication slowly enough that you can handle your symptoms and continue your daily activities. I tell patients it's as if their body is addicted to high levels of cortisone-like medications, and like all addictions, there will be withdrawal symptoms. These withdrawal symptoms cannot be avoided if the patient wants to get off steroids. The only way to make them less severe is to slow the taper. But it's up to the patient to decide if he or she wants to go through this process. If they can't handle it, they can't handle it. I tell them fine. Simply stay on a maintenance dose of glucocorticoid for the rest of your life. Many times patients want to load this responsibility back to you, but all we can do is give them the recipe. It's up to the patient to put up with the withdrawal symptoms. So this is a part of this handout we have. We list their steroid and we give them their taper. And again, the 4 times that you can take a glucocorticoid: breakfast, noontime, evening mealtime, bedtime. This is prednisone 10 and 5 for 2 weeks, 7.5 and 5 for 2 weeks, 7.5, 2.5, and finally 5 and 2.5. Once they get to 5 and 2.5, we switch them to equivalent dose for shorter acting glucocorticoid. If you keep them on prednisone, this dose, the hypothalamus is never going to wake up. So we need a shorter acting glucocorticoid, single dose in the morning. That's our goal. If the patient has intolerable glucocorticoid withdrawal symptoms, with this pace of taper, go back to the previous level, slow the pace, and instead of dropping every 2 weeks, you could drop every 3 weeks. Or you could decrease the amount of drop. Instead of 2.5 milligrams, you could drop by 1 milligram. Once they're on hydrocortisone, it's 20 and 10, 15 and 10, 15 and 5, 15 milligrams in the morning thereafter. If the patient wants to and can tolerate a faster taper, and every now and then I'm surprised. I mean, most patients actually, they want to get off steroids and they want to do it quickly. If they can do these drops every week, fantastic. The quicker, the better. And this is where we tell them how to get ready for that blood test. The day before the blood test, just take your morning dose of hydrocortisone. The day of your blood test, have the blood drawn before you take your morning dose of hydrocortisone. If your morning cortisol's normal, above 10 micrograms per DL, I'm sorry, if it's less than that, then we repeat those steps. Where if it's higher than that, we want them to contact us to confirm that, yes, they can stop their hydrocortisone. And this is an important point. Patients get distressed when they're, first of all, their cortisol levels are undetectable, then it goes to 1.6 microgram per DL, then it goes to 3 microgram per DL, then it drops back to 1.9. That's normal. That's typical. It doesn't go up in a straight line. The one caution here is if the patient's taken oral estrogens, that increases cortisol binding globulin, and we need to have a higher cutoff for our cortisol level rather than 10 micrograms per DL. If the patient becomes ill during the taper, they should follow sick day protocol, double their dose of glucocorticoid. If they have recurrent vomiting, they should be treated with IM or IV glucocorticoid and follow sick day protocol. As the endocrinologist, you provide the recipe for how to get off glucocorticoids. It's up to the patient to make it happen. If they can't tolerate the withdrawal symptoms, again, okay, treat with standard glucocorticoid replacement for life. Well, those are some of my tips and tricks in this process. I'll be happy to address any questions you may have during the Q&A section. Thank you very much for your attention.
Thank you, Professor Young, for wonderful presentation. I turn the microphone now to my colleague, Dr. Hussein.
Moving on, our next topic in adrenal is adrenal incidentalloma. The speaker is our friend, Dr. Ahmed Hassoun. He's very well known to all of us. He doesn't need any introduction. He was trained in Rhode Island, Brown University, and then he completed his fellowship in Mayo Clinic, Rochester, Minnesota. And then he became an attending in the Mayo Clinic. And he has actually been practicing for almost 20 years now in the United Arab Emirates. He's a fellow of the American College of Physicians. He's a fellow of the American College of Endocrinology. He's actually the co-founder of the Endocrine Club in the United Arab Emirates for the last 19 years. And it's good to know that Dr. Ahmed Hassoun is the first president. He was elected 9 years ago for this society, which used to be called ASCAL chapter. And he contributed significantly to this association. He actually is the one who founded the Endocrine Board Review that is used and attended by junior and senior endocrinologists in the Gulf area and even the MENA region. He received many awards. One of it is the Ibn Sina Distinguished Service Award. And he authored many papers, more than 50 articles in PubMed index journals. Dr. Ahmed Hassoun will be talking to us about adrenal incidentalloma. The floor is yours, Dr. Ahmed.
Thank you, my friend, Dr. Wiam. And I would like to start by thanking the organizing committee for inviting me to be with you today. But unfortunately, it would be very difficult to follow my mentor, Dr. Bill Young, after his excellent presentation as usual. My presentation is going to be addressing adrenal incidentalloma from a point of some practices that we encounter in our patient in Dubai. I have nothing to disclose. I'll try to give some few points about a background, presenting two cases that I have encountered, ending with some guidance to the approach available in the literature, and leave you with some take-home messages. I'm sure all of you are aware of incidentalloma definition. It's a mass in the adrenal. It's a lesion that is 1 centimeter usually or more. It's found during an examination for other cause of abdominal pain or chest pathology. And we have seen that this has been increasing significantly in the later years because of the advances in technology in CT scanning and MRI, and also the increased use in our clinical practice. And you can see here, the prevalence of this incidentalloma has increased significantly from the time in the late 80s, when it was estimated to be 0.4%. In 2001 publication, it went up to 4.4%. And later in 2017 and 2018 publication, estimated to be around 7.3%. And it's also known that it's more common in elderly, reaching 10%. And also studies of autopsies of people who are normotensive and hypertensive showed that in normotensive people, the autopsy showed 9% adrenal masses incidentalloma and 12% in people who were hypertensive. The incidence is the same, is really increasing significantly. Studies and in the 1995 shown here that the incidence was 4.4 per 100,000 person years, and significantly increased in 2017, tenfold, reaching to 47.8 per 100,000 person year. Tenfold increase since then. Now, I'm starting to just present to you my cases that I encountered, and you can see this case here is my first patient. Let me go back here, I think. Okay, here we go. It's an Arabic gentleman during his evaluation for abdominal pain, CT scan done to the abdomen and revealed the presence of 2 by 2 centimeter adrenal mass. And if I just can go back here, and you can see that's the mass highlighted there. And this was a contrast enhanced, so the Hounsfield was high, was 46. That's how they did it. The second case is about a Caucasian gentleman. During his evaluation for his chest, a CT scan of the chest revealed the presence of adrenal mass, which was later confirmed by MRI of the abdomen. And you can see this is the CT scan of the chest, showing the two, actually there are two, the left and the right, but the left is larger. And in the MRI, you can see it here as well. Now, what we need to know when we face such an incidentalloma is to discuss and to know, is it malignant or is it function or both? Is it malignant and is it functioning? These are the two important questions that we need to look at. So going into the malignancy points of the adrenal incidentalloma, it is estimated that the frequency of primary adrenal carcinoma reaching 2 to 5%, depending on the studies, and non-adrenal metastasis in the incidentalloma is lower, 0.7 to 2.5%, although this has been probably increased lately with the advances in managing cancers. The predictors of being malignant is the older age, male gender, larger size, more than 4 centimeters usually, and higher unenhanced CT scan attenuation. A study from our group at Mayo Clinic, led by our friend, Dr. Young, an Olmsted County resident, they looked into the incidentalloma and published that in 2020. 3.3% were malignant only, 88% adenoma, 0.8% pheochromocytoma, and 7.8% were other benign tumors such as myelolipoma, hematoma, and others. If you look at the adenoma, you could see that Cushing syndrome and primary hyperaldo were about 1.1%, followed a higher level of subclinical Cushing syndrome, non-functioning adenoma, and some other adenoma that were apparently not known their hormone status during reviewing them. Now, the question again is it functioning, as we said? So to look into the functioning, I don't want to bother you with Cushing syndrome, but this is one of the clinical features that we see in people with high cortisol level, and you can see it here, and I'm sure most of you are aware of this. And also to look into clinical features of the other hormones secreted by the adrenals, such as catecholamines in the excess. And you can see these are some of the symptoms that we encounter in people, such as the people with pheochromocytoma or aldosterone excess, and that's mainly really being hypertensive or having hypokalemia. Now, in addition to that, so some of these masses and some of these patients don't have the symptoms, they don't have the clinical features, but they might have secretion of these hormones. So it is recommended to check biochemical status of these masses. And as you can see here, hypercortisolism, primary aldo, pheo, and adrenal androgen excess, especially in women. And these are the recommended tests that we are doing. Going back to my first patient, and I'm just highlighting here the history and the physical. And I know you don't have time to read it all, but basically you can trust me. There was no clinical features of Cushing syndrome, and there were no clinical features of catecholamine excess or hyperaldo. He was not hypertensive. And actually, they recommended, as this is published and presented by Dr. Young many times, this is the initial investigation that we need to do in our patients in subclinical Cushing to look into 1 milligram dex suppression, DHEAS. And if CT scan, not in our case, was done unenhanced, and it was more than 10 Hounsfield unit to measure the catecholamines as mentioned here. And if the patient, again, not in our case, if has hypertension or hypokalemia, then we need to check plasma aldosterone and plasma renin. Now, this is my patient, the first case. Potassium was okay, no hypertension, no hyperaldo was evaluated in this case, but we have checked for the cortisol, and you can see some confusing numbers in the ACTH was suppressed here. I was thinking that that was probably done by wrong from the lab itself, whether it's how to take it from to the lab, or it was done in the wrong time. That was before I was involved in the case. Cortisol AM was also on the lower normal range, 7.1. But because of that, and because of the recommendation, we did the catecholamines in this case, because we did not have an unenhanced level. So the enhanced contrast CT was high, and we needed to really exclude pheo or catecholamine axis. And you can see that all the numbers for 24-hour urine studies of the catecholamine and metanephrines were all within normal range. So we did the free cortisol, and again, you can see 24-hour urinary free cortisol. By the way, this is done different time, and you can see that it is higher, more than double than the upper normal range. But when I reviewed the case, I saw that the urine volume was very high, and I have discussed some similar cases with my mentor and colleague, Dr. Young, and this is very important to correlate with the urine volume. So the urine volume in this case was 5.8 liters, surprisingly. Now, for that reason, we need to be sure that we are not missing, or we need to confirm if he really have hypercortisolism. We did the 1 milligram dex suppression test, and the cortisol was suppressed 1.46 microgram. And also we did salivary cortisol late night, and that was low also. So now the question about this case, is it functioning? We felt it is not functioning. Is it malignant? We need to look into that. This is a very nice table. I think I need you to probably look into the reference of it. It is in the endocrine practice by Vidya, and it was presented in one of the conferences as well, published in 2019. You can see there's characteristics of the imaging of adrenal masses that make you feel it is more likely to be benign or suspicious for malignancy. And I'm going to highlight for you something relevant to our cases today. The size, if it is less than 4, is likely to be benign. And density on non-contrast, which we did not have in the first case, and even probably the other case, it is less than 10, it is benign. And if it is more, it is likely to be malignant. But we have contrast washout on CT protocol 10 to 15 minutes in the case, and it should be, if it's benign, absolute reduction 60% or more. And also we have MRI chemical shift done on the study, and if it is a positive shift, then it is actually more with the likely to be benign. This is a paper that was presented many years ago and published in 2003, just showing the same principle of the contrast enhanced. As you can see, lipid rich, lipid poor, non-adenomas, and including pheo and probably also the cancers here. You can see that unenhanced is very low in people with lipid rich, which we mean adenoma here. And even in the lipid poor, it is a little bit higher. But if you go to the second part here, you can see the true percentage washout is, again, in both cases, whether it is lipid rich or lipid poor adenoma, they will significantly reduce more than 60% in both. Unlike in the one that is, you can see, non-adenomatous, and including for example, the cancers here. This is our patient. This is again done and looked into that and reviewed with the radiologist. And you can see here that the mass here, as we mentioned earlier, the Hounsfield was 46. This is a coronal view. And the one delayed image shown here to show the washout, it was 46 went to 16, and the 65% was the washout. Again, in a different view here, looking into, again, the same washout time, and you can see it's, again, almost the same number, 65% reduction after the delayed image. This is another paper published, an important one, in American College of Radiology in 2017, looking into the adrenal CT washout significant, looking into our case here, the absolute washout 60% or more, signify benign adenoma, and actually in these cases it's recommended, they are non-functional and recommended to be no follow-up. Our case, the first case again, went into an MRI study. They were doing more MRI rather than CT in my new place, and look at this one here. You can see that the mass measurement in the MRI in phase, but the important part again here is the chemical shift, or what we call MRI out of phase. There was loss of signal, as you can see here, signifying more of a benign nature of this mass. So now with this, we could say it looks like non-functioning. It is less likely radiologically, malignant. And going to our friend and mentor, Dr. Young, this is one of the algorithms. I have modified maybe the colors or something in it, minor. I know he will forgive me if I did something different a little bit, but you can see here, looking at the imaging phenotype on our first case. Now, the question is, if you have these two, but what we have in our case, we have these things. CT contrast washout more than 60%. MRI chemical shift was there. Size less than 4. Most of it looked into a benign nature. Unfortunately, the patient underwent and decided to go for surgery after counseling with the surgeon, and the surgeon were discussing with the patient about some of the features that really not significant, but the patient was leaned more for doing the surgery. And this is what happened as the pathology of the surgery turned to be benign non-functional adenoma. And the course went very well, smooth, without any complication, peri or post surgically. The second case, again, I don't want you to bother on this. I just highlighted in red for you some of the important points here. Family history, there is hypertension. There is question of adrenal adenoma. We're not sure of it. And the patient was not clear about it. Past history of the patient himself has type 2 diabetes and hypertension as well. So if you look at the features of Cushing syndrome, nothing except being diabetic and having hypertension, which are significant. And with regard to catecholamine or hyperaldo, again, he has hypertension in that regard. So the patient underwent evaluation before coming to see us. And that was actually, this is done in our center before. And that's, you can see that this was showing all of them are benign. So it's a non-functioning again. And just to look into the picture, this is the CT scan of the chest showing the mass. And this is again in an MRI done. And this is the measurement in 2017, the first time seen. And according to that outside record, actually this is an outside record, showing that the measurement is, in the right is 17 millimeter in the highest diameter and 37 on the left side. And the question or the diagnosis was mentioned that it looks like more of a benign adrenal myelolipoma. This was given to us later on after we asked him to bring it. But while he was with us in the clinic, he asked us to be sure that of the diagnosis, and he underwent further evaluation. As I told you, the functionality was done. It was normal, non-functioning. And this is an MRI done soon in 2018 as a follow-up. I think it's about 7 months or 8 months from the first study done outside. And again, the message from here is, again, the MRI chemical shift was done. We did not have at that center before CT scan. They were depending much more on the MRI investigation. And we can see that it is signifies for benign nature of these two masses. Now, looking into this and looking into the same paper of the radiology, you can see that the diagnostic benign imaging features, if you have that, different than if you have intermediate or worse. And these are the people who are recommended. For example, if it was myelolipoma and no enhancement, then you have to think it is really benign and no follow-up is needed. Again, if somebody is less than 10 Hounsfield unit, again, benign nature. And mentioned here also the masses with diagnosis of benign nature, including the myelolipoma, as we know, cyst, hemorrhage, and other masses mentioned here. So I will just move to the guidance approaches that my colleague and mentor, Professor Young, who have always taught us how to go with this. And you can see here, without going into the details of it, that you start with initiating of hormonal evaluation secretion, as we mentioned earlier. But if it is secreting and functional, then you need to confirm it and consider surgery if it is positive. If you could not confirm it, then you go again looking into the imaging phenotype based on the initial imaging. Again, looking at the CT scan, Bill Young and all of us, I think, are depending much more on CT scan protocols and others at Mayo Clinic. I'm not sure if Bill has some update on this. Unenhanced CT attenuation, contrast washout, all benign. If it is yes, again, you go for repeat imaging and follow-up, and maybe periodically every year you do some testing on these cases, and surgery if it is large. Now, if it is not, then you go to have a consideration of biopsy, depending if the patient have history of metastasis or infection, and surgery if physically fit, and basically follow-up, close follow-up. If not, have the surgery at that time. This is from the paper I mentioned to you by Vaidya in the endocrine practice, published in 2019, and summarizing here, in a way, somewhat similar approach with some differences, minor differences here, again, to biochemical evaluation, radiographical characteristic here again. The main thing here, if I just can move this here, is the surveillance. And this is something new that are recommended. So if there is no high-grade evidence for surgery, surveillance consideration, and divided into two types. If initially non-functional, these masses, and no high-grade evidence to support repeated biochemical testing. Consider repeating biochemical testing if worsening comorbidities suspicious for cortisol or aldosterone. That time you do. And if autonomous cortisol secretion, but without clinical syndrome, individualized consideration for surgery based on the comorbidities and other factors. Consider longitudinal biochemical surveillance, and no high-grade evidence to support longitudinal radiographic surveillance. So I will end with giving you some take-home messages from what we have learned and from what is in the literature. We know now that the prevalence is really increasing more with the technology we have, including the prevalence and the incidence. And majority of these adrenal incidentelloma are found to be benign. Majority of adrenal incidentelloma are non-functioning cortical adenoma. Imaging characteristics is very important. All the recommendations are to look into the imaging. And this is something important I find that we need to discuss with our radiologists, and to find the protocols that are suitable for our patients. Are essential to look into the characteristics of the images to guide the approach in management, as we have seen earlier. Always exclude pheochromocytoma if unenhanced CT Hounsfield more than 10. Evaluate for hyperaldo only if patient has hypertension or hypokalemia. Now we're talking about this adrenal incidentelloma. And last but not least, longitudinal biochemical and radiographic surveillance should be individualized depending on case by case. And with that, I would like to stop here, and thank you very much for listening.
Dr. Ahmed, that was very nice and brilliant talk. Thank you very much. I have to say that the Cleveland Clinic team here is very happy from the Mayo Clinic team. They are sticking by time, and actually we are very early, so that will give us more time for the questions and answers. I'll hand over now to my co-chair, Dr. Hussein, for the next speaker.
Thank you, Dr. Wiam. It's my pleasure to introduce our next speaker, Dr. Musa Al-Maliki. who is currently a consultant endocrinologist at King Fahd Medical City. Dr. Al-Maliki finished his residency training in Saudi Arabia and then went to the University of British Columbia, where he completed a fellowship in endocrinology, followed by 1 year of fellowship in pituitary disorders. And he went back to Saudi Arabia, where he is currently practicing. He is well known in the field and has published tremendously. Please welcome Dr. Musa Al-Maliki.
Assalamu alaikum wa rahmatullahi wa barakatuh. Good evening, everyone. It is my pleasure to be here with you this evening. First of all, thanks for that kind introduction. And I would like to thank the scientific committee for having me to speak about diabetes insipidus. I have nothing to disclose. This is the outline of my talk: how to make a diagnosis of DI, know the limitations of classic test of DI, understand the background of Kubeptem as new diagnostic tool of DI, know the management of patients with different forms of DI, discuss the post-operative DI, how to approach a patient with a Dipstick DI, and finally, we'll review the association of COVID-19 and DI. DI is belong to a spectrum of polyuria polydipsia syndrome, which is a group of hereditary or acquired disorder, which is characterized by polyuria of more than 50 ml per kilogram per 24 hours that's accompanied by polydipsia. And as you can see here, it is a result of 3 basic defects. In central DI, there is decrease in secretion of antidiuretic hormone, while nephrogenic diabetes insipidus, there is renal resistance to the action of antidiuretic hormone. While primary polydipsia, this is excessive and prolonged water intake for prolonged periods of time, which lead to physiological suppression of antidiuretic hormone. So there are several other conditions can present with polyuria. It should be ruled out before labeling a patient with DI. As you can see here, at the top of the list, hyperglycemia and solid diuresis, which can be easily differentiated from DI by the simultaneous measurement of serum and plasma osmolality. Of course, certain medication like diuretic or use of SGLT2 inhibitors in diabetic patient can present with significant polyuria. In acute setting and post-operative time, acute drop of growth hormone after successful pituitary surgery for growth hormone secreting pituitary adenoma can present with polyuria. Central DI, this represents the most common form, which can be due to the either complete or partial deficiency of antidiuretic hormone, can occur at any age in both sexes. This can be a result of either inherited or acquired condition. Among the acquired condition, hypothalamic lesion, which account for up to 40 to 50% of the cases, like tumor, sarcoidosis, trauma, or subarachnoid hemorrhage. DI in the context of pituitary adenoma is not that common before surgery. However, if it is present, we should this should raise suspicion of other diagnoses like craniopharyngioma. Idiopathic, this is diagnosis by exclusion, but has been reported in 20 to 50% of the cases. And the autoimmune process have been described in a subset of patients who was initially diagnosed to have idiopathic DI. Genetic represent in about less than 5% of the cases. Nephrogenic DI, this is a result from the renal resistance to the action of antidiuretic hormone. It is less severe and less common than central DI. This might be due to acquired or inherited condition. In children, it is almost always due to inherited condition. While in adult age group, this result from the acquired condition most of the time. And the most common acquired causes include electrolyte disorder like hypokalemia, hypercalcemia, or hypercalciuria. Also, medication is frequently associated with nephrogenic DI. Lithium is at the top of the list of medication, which involves in about 10 to 20% of the cases in patients, especially in patients with long-term use of lithium. Primary polydipsia is a result from excessive and prolonged water intake. So there is no defect in the antidiuretic hormone secretion or action. And this, it could be dipsogenic if there is a defect in thirst mechanism. and it can be psychogenic in the context of psychiatric disorder. So how to evaluate patients suspected to have DI? The first step is to differentiate polyuria from the most common complaint, which is frequency. Once you are in doubt, 24-hour urine collection, it can be helpful. So once polyuria is confirmed, the second step is to measure urine osmolality and specific gravity. So once hypotonic polyuria is confirmed, the third step is to differentiate the type of DI. However, the clinical picture is not always black or white, as there is some overlap in between. And finally, evaluation for the underlying cause. So to differentiate which type of DI, and water deprivation test or indirect test is water deprivation test, which is the most widely used, can be done as outpatient, where we start the fluid restriction overnight, so the dehydration occur while patient sleeping, and with measurement of morning serum sodium and urine osmolality. Urine osmolality more than 800 or more than 600 exclude DI. However, in patient with severe disease, it should be done in inpatient setting and under supervision. The test should be suspended if there is 5% or more reduction of weight from baseline, or urine osmolality plateau for 2 to 3 consecutive reading, or sodium or serum sodium exceed 145 millimole per liter. Here we demonstrate desmopressin and evaluate urine osmolality and volume Q30 minutes for 2 hours. How to interpret the result? As you can see here, this is as per diagnostic criteria that proposed by Miller in 1970. A normal subject, usually urine osmolality more than 800 with no further increase after administration of desmopressin. In patient with complete DI, usually urine osmolality less than 300. But if you give desmopressin and you found increment of urine osmolality more than 50%, this is going with the complete central DI. If it is less than 50%, this is going with the nephrogenic DI. However, in patient with partial central DI or primary polydipsia, urine osmolality usually between 300 and 800. Here we give desmopressin again. If increment more than 9%, this is suggestive partial central DI. If it is less than 9%, this indicates primary polydipsia. However, water deprivation test is widely used and considered the gold standard, but it is suffer from several limitations, including it is not convenient, exhausting for patient, and needs supervision, especially in severe DI. There is overlap in test results in patients with primary polydipsia and partial form. Also, diagnostic accuracy only reported in 70% of the cases, and in patient with primary polydipsia only in 41% of the cases. In addition to that, the sensitivity and specificity for different cutoff and differential diagnosis of different form of DI have not been defined. Measurement of AVB as a direct test, as the AVB, it plays an important role in the water regulation and osmoregulatory function. It has been suggested as an alternative to the water deprivation test to overcome all limitations associated with that test, and with hoping to provide a convenient and rapid diagnostic measure. So the result usually compared with the area of normality in the normogram. If it is lie within the shaded area, this is suggestive primary polydipsia. If it is above the shaded area, this is indicate nephrogenic DI. If it is below, this is going with the central DI. However, it doesn't enter routine clinical practice because it has several limitations. First of all, it is difficult to measure because it has a complex pre-analytical requirement. It has short half-life from 10 to 30 minutes. Also, it's bound to platelet up to 90%, so it might overestimate or underestimate the result. And finally, the sample is stable for 24 to 48 hours at 4 degrees centigrade. And the turnaround time for the result up to 7 to 10 days. So this might affect the stability of the result. Due to all previous limitation, the Kubeptem, it has been suggested as the alternative, and the Kubeptem is a peptide that derived from the same precursor of vasopressin. The main function is largely unknown, but it has been proposed as the stable surrogate marker for the endogenous vasopressin concentration. The Kubeptem has been evaluated in several studies and found to be strongly associated with the vasopressin at wide range of plasma osmolality. In addition to this, it has several advantages. We need a small amount of blood, around 50 microliter, as compared to 1 ml for the vasopressin. It's stable at room temperature for up to 7 days and can extend up to 14 days at 4 degrees centigrade, and we can get the result within a short period of time, up to 2.5 hours. This algorithm summarizes the use of Kubeptem for differential diagnosis of different forms of DI at the baseline without prior testing. If it is more than 21.4, this is indicate nephrogenic DI with high sensitivity and specificity. If it is less than 2.6, this is indicate central complete DI. If it is in between, we have to do water stimulation, water deprivation test, or we give hypertonic saline stimulation to ensure sodium more than 147 millimole per liter. If the stimulate Kubeptem less than 4.9, this is suggestive partial central DI. If it is more than 4.9, this indicate primary polydipsia. MRI, this emerged as another diagnostic tool in addition to biochemical testing, and with focus mainly on the infundibulum and posterior bright spot, although both of them non-sensitive or specific. Bright spot, it can be absent in 20% of healthy subject, and can present also in 30% of patients with documented central DI, especially at the first stage. But it's very helpful, especially when you are evaluating for the underlying cause. Therapeutic trial of desmopressin, it can be done in case of there is still uncertainty about diagnosis, or if you work in a situation where there is limited resources. So we give 10 mic of desmopressin intranasally, 2 times daily for 2 to 3 days, and look for the response. If there is significant reduction, if urine output, nephrogenic DI is excluded. If there is significant reduction of urine output and water intake with no hyponatremia, this indicates central DI. In case of there is significant reduction of urine output without a change in water intake and with development of hyponatremia, this is most likely going with the primary polydipsia. Now we'll move to treatment, and treatment should be according to the type and according to the cause. The aim of treatment is to improve patient quality of life and to maintain water and electrolyte balance. In case of central DI, treatment mainly desmopressin, which is synthetic analog of antidiuretic hormone, and most of the time it is lifelong, except after pituitary surgery, where the treatment is where most of the time it's transient and there is no need for fixed treatment. This table summarizes the dosing and formulation of desmopressin, and all of them effective and can reduce urine output within 1 to 2 hours, and the duration of action from 6 to 18 hours. Usually start with the night dose to control nocturia, then adjust according to the response on weekly basis till we reach the stable dose. Treatment of nephrogenic DI, here might be slightly complex as compared to central DI, with focus mainly on the underlying disorder, if possible, like hypokalemia or hypercalcemia, or discontinuation of the offending medication, if possible. Desmopressin, it can help, especially in patients with partial nephrogenic DI, but they usually require higher dose. But the most important aspect of treatment here is diet, which should minimize the osmotically active substance, this in form of low protein and low salt diet. Thiazide diuretic, it's another important key in management of nephrogenic DI, which lead to decreased urine output and increase urine osmolality. Amiloride, it can be added to thiazide diuretic to enhance its efficacy and to minimize hypokalemia as a side effect of thiazide diuretic. Also, it can be used in case of the lithium-induced DI. Primary polydipsia, there is no effective medical treatment for this condition, and the mainstay treatment is behavioral therapy to decrease voluntary water intake. Supportive measure, of course, is very important, like the avoiding any medication that can cause mouth dryness, eating well-balanced diet, and the maybe daily weight to assess for the water of being retained, and patient education about the disease and about hyponatremia. Now we'll move to the post-op DI. This is a common condition which occurs in about 46% of the cases, and most of the time it is transient. However, 2 to 10% of the cases can be permanent. Some patients, they are at risk of post-op as compared to other, and this has been explored in several studies, and they found patients with functioning pituitary tumor like Cushing disease at risk of DI as compared to other type of tumor. Patients who underwent extensive intraoperative manipulation of posterior pituitary at more risk. Similarly, the intraoperative CSF leak more likely to be associated with the DI as well. Post-op DI can take several forms. It can be transient with one phase. It can be permanent if there is more than 85% destruction of magnocellular neuron of the hypothalamus. It can be triphasic response, or it can be biphasic response. And the initial diagnosis required to have hypotonic polyuria, which is defined to have urine output more than 300 ml per hour for 3 consecutive hours, and urine specific gravity less than 1.005, in addition to at least one of the 3 relative criteria: excessive thirst, serum osmolality more than 300, or serum sodium more than 145. What about Kubeptem? We all know that the Kubeptem role is well established in patients with persistent DI, but in post-operative is still not validated yet and require further study. This diagram summarizes the initial diagnosis and treatment of post-op DI, and the most important aspect of management of this condition that we need the shared care between endocrinologist and neurosurgeon, and the also patient should allow to have access to water and should be kept under close monitoring. In case of the documented DI, the patient should be given desmopressin MBRN basis and assess the response. In case of persistent DI, we have to give another dose as needed. At the same time, we have to evaluate for sign of resolution of transient DI and for the triphasic response. If the fluid balance positive more than 2 liters, here we have to suspect the second phase or an appropriate antidiuresis. So we have to start fluid restriction and to suspend desmopressin. A dipstick DI, this is another challenging and rare endocrine condition, occur mainly in patients with the higher lesion above the median eminence, like patient with a large craniopharyngioma, or patient underwent surgery for the anterior communicating artery aneurysm. This patient, they have DI in addition to the impaired thirst mechanism. So they are at risk of the sodium dysregulation. So they can fluctuate between hypernatremia and hyponatremia. In addition to that, they are at risk of the hypothalamic-related complication like obesity, sleep apnea, and seizures. So how to manage this patient? The principle of management, as outlined by Ball in 1997, the most important step is to set a target weight when the patient known to be eupholemic and normonatremic. Patient should be given a desmopressin and fixed dose to ensure adequate antidiuresis. Also, we have to determine the obligate fluid intake, the amount of fluid he needed on daily basis from 1.5 to 2 liters, depending on the patient health condition and weather. And also we have to do daily weight measurement to detect any change in the weight. For example, if you detect around, for example, 1 kilogram from the baseline. So 1 kilogram, this will be equal to 1 liter. This should be added to the obligate fluid intake. Also, we have to keep eye on the serum sodium, and another important aspect of management, patient and family education about importance of the water balance and management. The last aspect of the last section of my presentation was COVID-19 and DI. DI has been described in literature in patients with the COVID-19, and the central DI believed to be due to the either direct or immune-mediated neurohypophysitis, or due to the hypoxic encephalopathy, especially in patients with the severe respiratory failure. On the other hand, nephrogenic DI has been described as well as consequences of sedation in patient in ICU setting who underwent intubation. The management is the same principle of management of patients with DI. You have to ensure adequate fluid replacement, supplement of desmopressin, and with the close monitoring of the fluid balance and with the electrolyte monitoring. What about patient with pre-existing DI? The patient with the existing DI at risk of the complication of the serum sodium abnormalities. Hyponatremia most commonly reported, and most of the times delusional as a result of the chronic desmopressin, and majority of patient is mild. However, severe hyponatremia with sodium less than 130 has been reported in 15% of the cases, and this can be prevented by regular check of serum sodium. Also, patient advised to do the periodic withhold of desmopressin administration to give a period of free water clearance. On the other hand, hypernatremia is less common, but it has been reported, especially in patients with severe COVID who admitted to intensive care unit. And this might be due to the insensible water loss or inadequate water intake, or it might be due to the decreased absorption of the intranasal desmopressin. Hypernatremia also found to be developed rapidly in the DI patient with severe COVID. So how to manage patient with DI or develop COVID? The principle of management has been highlighted in the last clinical practice guideline published in the European Endocrine Society. And as you can see here, in the outpatient setting, the advice to give priority to avoid hyponatremia, and this is emphasize the importance of the delaying the desmopressin dose. While in inpatient setting, if patients have mild COVID, the advice to switch from the nasal to oral desmopressin and to ensure adequate fluid intake. While in patients with severe COVID, they are advised to give IV desmopressin and to give adequate amount of fluid. Should be given intravenously as well, and to give routine prophylactic low molecular weight heparin during the episode of hypernatremia, because hypernatremia is well known as a hypercoagulable state. In addition to the pulmonary embolism is another emerging condition in the COVID-19. And as a majority of patients with central post-op or post-traumatic DI, they have the ACTH deficiency, the advice to give a stress dose of steroid. So in summary, DI is a rare condition, but should be evaluated in any patient with documented hypotonic polyuria to avoid the complication and to maintain fluid and electrolyte balance. The role of Kubeptem is well established in differential diagnosis of different forms of DI, but it's still not well validated in patient in post-operative DI. Treatment of post-op DI should be individualized, and this depends on the duration and severity of disease. Management of a Dipstick DI is a complex and require training and collaboration of patient and their relative. Body weight can be served as a surrogate marker for adequate water and sodium balance. Patients with central DI and COVID should learn how to avoid delusional hyponatremia. Hyponatremia seems to be a common in COVID-19 in intensive care setting and potentially associated with poor outcome. With this, I would conclude my presentation, and I would be happy to answer any question. Thank you.
Thank you very much. It was very informative and very outstanding talk. Now we move to our fourth speaker for today. The topic is growth hormone deficiency in adults, a very important topic. Dr. Salim Beshaya is the speaker. He's well known to all of us. He's a colleague and a friend. He's a consultant endocrinologist in a private practice, Mediclinic Airport Road in Abu Dhabi. He's also a professor at the Dubai Medical College. He has an extensive training after graduating from Tripoli, from medical school in the UK, and wind up doing at the end 4 years of clinical research at St. Mary's Hospital, Medical School, and Imperial College of London, where he did his PhD, and it was concerning the hypopituitarism and growth hormone deficiency. He had 23 years of experience as a senior physician and have a special interest in cultural aspects of medicine, education, and culturally relevant clinical research. He had more than 80 papers published in the PubMed Index and much more than that in other journals. He's also the previous editor-in-chief for Ibn Sina Journal of Medicine and Biochemical Science. And for the last year, he's been the editor-in-chief for our journal, the Diabetes and Endocrine Practice for the association. One thing important is Dr. Salim is one of the founding board members of this association 9 years ago, and he was actually the past president of the American Association of Clinical Endocrinologists, the Gulf chapter. We are very pleased to have you, Dr. Salim. The floor is yours.
Thank you very much. Assalamu alaikum wa rahmatullah. Thank you very much for that very kind introduction. It is my pleasure to talk tonight in this conference. And the subject is on growth hormone deficiency in adults, or exactly in its deficiency and the benefit of its replacement. I have no conflicts of interest in relationship to this presentation, other than I spent 4 years doing research on growth hormone deficiency in adults. I thought to divide these educational objectives of the session into 3 items: to review first the clinical and metabolic impact of growth hormone deficiency in adults, discuss the benefits and the side effects of growth hormone replacement therapy in adults, and also highlight the guidelines and touch on some of the practical points for the replacement in adult persons. Now, to start with, it may sound like contradiction of terms when you talk about growth hormone in adults, because adults do not grow. However, this is the original name, and the fact that it was restricted to children many years ago is based on the restrictions of availability of the pituitary cadaveric growth hormone till it became biosynthetically available. And that's why when we rediscovered a new condition called growth hormone deficiency in adults, or growth hormone deficiency syndrome in adults. The estimated epidemiology, we talk about etiology of adult growth hormone deficiency as 2 groups of patients. Those who come to us from our pediatric colleagues, the childhood onset, these are a result of structural lesions or traumatic brain injury, but also they could be related to congenital or genetic basis, and also there are some idiopathic conditions. Whereas in the adult practice, for those particularly who are running neuroendocrine clinics, they will actually come across adult onset patients with either acquired or idiopathic conditions. The estimated number of adult growth hormone deficiency is about 1 in 20,000 to 1 in 25,000 per population. The acquired causes of adult growth hormone deficiency of adult onset type is mainly related to pituitary or parapituitary lesions and their treatment, that being surgery or radiotherapy. However, more recently, it has been suggested that brain injury, including trauma such as sport trauma, blast injuries, subarachnoid hemorrhage, strokes, etc., these may actually outnumber the pituitary adenomas in causing adult growth hormone deficiency, and there are data to suggest that in senior or old or retired sports people. There are, of course, a long list of other causes of adult growth hormone deficiency. The point that I would mention, perhaps we still have, even in our age, we can still see more than what we need to see of patients with Sheehan syndrome, which is on the bottom of the list of this one here. So what are the clinical consequences of having a deficiency of a hormone that's called growth hormone in an adult person? And instead of showing so many data slides, I actually used this summary slide here to show the 4 points where adult growth hormone deficiency affects the individuals with this deficiency. Number one is the abnormalities of body composition, which has been shown using several methods: increased body fat, decreased lean body mass, reduced bone mineral density. This has been shown with DEXA, it has been shown with total body potassium, bioelectrical impedance, etc. All methods of body composition analysis confirmed the same. The second one was the increased cardiovascular risk. To start with, there was the Swedish data that suggested from epidemiological analysis that there increased mortality in comparison with non-hypopituitary patients or non-growth hormone deficiency patients. But further analysis also illustrated specifically that there is an increased numbers of strokes and cardiac events. We at St. Mary's, what we've done, we looked at asymptomatic patients, patients who do not have evidence of cardiovascular disease, and we looked at their cardiac function structure, and we looked at their intima media thickness. And we actually published that in the early 90s, showing that even in asymptomatic patients, there is evidence of abnormalities. Also, as a preparation to treat these patients with the growth hormone, we actually measured their lipids and done oral glucose tolerance test on them. And to our surprise, we found that the lipid profiles are disadvantageous. And also, to the contrary to what we expected, there is actually increased frequency of glucose intolerance. Impaired quality of life has been illustrated using several methods, several quality of life measures. And the current one, which is the standard method, is the adult growth hormone deficiency instrument that's actually available in English and in many languages. And we have been attempting to make a formal one in Arabic, but the work is not being complete. The impaired physical well-being, decreased exercise capacity has been shown, and reduced muscle mass and strength has been shown by several workers from Europe and North America. So how will we make a diagnosis of growth hormone deficiency in adults? It's similar to any other condition. You have to firstly put the clinical context by the clinical findings, full medical history, and then think whether there is a need to do growth hormone stimulation test or not. What we think, there are groups who do not need any growth hormone stimulation testing, and there are groups who need stimulation testing. But I will show just a single slide where growth hormone testing is not needed. In patients with childhood growth hormone deficiency who are known to have conditions that will not go away by time, such as genetic mutations, neuropathic lesions, or irreversible structural lesions or damage. Also, patients who are adult onset of growth hormone deficiency who have several pituitary hormone deficiency. We have illustrated that using IGF-1 and the number of hormones. Also, the group from Kiel also is shown the same. So it is now the more number of pituitary hormones are lost, the less likely that actually you need to test, and it is more, and within the clinical context, more acceptable to make a diagnosis of growth hormone deficiency. What are the tests? Is similar to what our colleagues in children care practice use. The standard one, the insulin tolerance test, but also growth hormone releasing hormone and arginine test can be used. Glucagon stimulation testing can be used, and also ghrelin test can be used. For most of the trials, they actually ask for 2 tests. The difference between the children and adults for this in this context is that the peak growth hormone response required to make a diagnosis in adults is limited to the severe adult growth hormone deficiency, which is a maximum response of less than 3 micrograms per liter. Although there are some variations. The reason why only severe adult growth hormone deficiency is included in the diagnosis that the benefit has been shown only in those with severe growth hormone deficiency in adults. So what are the demonstrated benefits for growth hormone treatment? These are the first two papers published in 1989, the first one in the Lancet and the second one in the New England Journal of Medicine. The first one is from Aarhus, the Danish group. The first author is Jens Jorgensen, who actually came and spoke in our conference a couple of years ago, and that was led by the late Jens Christensen. The second group by the research workers were Franco Solomon from Switzerland and Ross Cuneo, originally from New Zealand or Australia. And it was led by Peter Songson, who actually happened to examine my PhD a few years later. So just in summary, so that just in case we run short of time, the benefit is mirror image or opposite mirror image for what is being shown as deficiency. Body composition, reduction in fat mass, increase in lean body mass, increase muscle strength. Bone metabolism, increase bone mineral density, but that you need at least 12 months of treatment to show that. That continue to be persistent, the benefit is persistent over several years. The cardiovascular risk, all the classical risk profiles has improved, and also reduction in the diastolic blood pressure. Health-related quality of life has been shown using several questionnaire methods, and also some interview methods. Mortality would probably has been shown to will probably be reduced because of the correction of all of these factors. This the body composition effects would have been the most consistent in all the trials. So reduction in body fat, reduction in truncal fat and visceral fat, increase in the lean body mass, muscle strength, and exercise capacity. Bone metabolism, as I mentioned, actually bone density has increased, and there was a progressive gain in bone mineral content over 33 to 45 months. The cardiovascular risk, as you expect, all the classical risk factors and move into the right direction, including total cholesterol, LDL, blood pressure, C-reactive protein, and arterial structure has been shown. Both intermediate thickness that we shown originally that it is increased in our cohort. Growth hormone therapy also may protect against myocardial infarction, and these data from a retrospective study shown the increased rate of MIs in untreated patients and decreased rate in the treated group. Later data also showed there is an increase in the stroke events, particularly in women ×3 and in men ×2. And after initial treatment, the stroke incidence declines in both sexes. This is just one example of health-related quality of life improvement. As you can see, both in the group as a whole and in adult onset and childhood onset, there is improvement. Of course, there is a lot of factors that influence this, but I think at least the direction is in the right way. When we treat patients, we have to be careful about few things. These are normally transient, such as edema, carpal tunnel syndrome, musculoskeletal aches and pains, mainly because of fluid retention. The serious concerns were about the risk of malignancy and the insulin sensitivity, and I will discuss this in more detail. Malignancy, we can consider it under 3 groups. Patients who have never had cancer, there's no evidence to suggest that the doses you use in growth hormone replacement will actually increase the de novo cancer. Patients in complete remission from a tumor or malignant disease, again, there's no association. And patients who are survivors of childhood cancer, there's slight increase in secondary neoplasms. The insulin sensitivity, we know growth hormone per se is actually an antagonist of insulin, and therefore depends on the benefit you get from the body composition. To start with, there is a transient decrease in insulin sensitivity, but in the long term, there is 1 year, for example, of growth hormone replacement is relatively safe. And in some studies, there is an improvement in insulin sensitivity. In patients with diabetes mellitus, then we have all the methods how to adjust the doses as required. There are several guidelines. The latest comes from the ACE and the ACE 2019, but as you can see, actually, because of the controversial issue, there's so many guidelines before. But I think the most comprehensive, detailed guidelines are in the 2019 document. These are the doses. In young men, you can start 0.2 milligrams per day. In young women, 0.3 milligrams. And in older people, you get half of the dose. The dosing, you should consider sex, should consider the estrogen status and age, and the doses can be titrated according to the clinical response, the side effects, and the serum IGF-1 level. The standard monitoring should be done at 1 to 2 months and include the serum IGF-1, which should be maintained below the upper limit of the normal range when titrating the doses. Biochemical tests for safety and pituitary gland in patients who have disease in the past. Of course, patients should be interviewed as usual for any adverse events, and the dose should be adjusted. So I think to conclude, Mr. Chairman, adult growth hormone deficiency is now defined as a condition with distinct clinical and diagnostic features. The features are different in childhood onset and adult onset patients. A proper transition of pediatric children should allow a careful assessment of the needs of these patients, whether they need to continue on the treatment or they had their share and there's no need for to continue. The diagnosis, as usual in clinical practice, is based on the context, clinical context, and selection of standard biochemical investigations. The benefits of growth hormone replacement therapy include improvement in body composition consistently, bone metabolism, albeit at a later stage, the correctly used health-related quality of life, and cardiovascular risk and mortality. Growth hormone replacement therapy is generally safe, and signs of overdose are either transient or manageable. Thank you very much.
Thank you so much, Salim. That was a brilliant talk. We really appreciate it. This is a very tough topic, and I have to say this is an undertreated and underdiagnosed in this part of the world. I'd like all the panelists to join us, Dr. William Young, Dr. Musa Al-Malki, Dr. Ahmed Hassoun, and ask the audience to start sending more questions. I'll hand over now the question and answer session to Dr. Hussein Saadi.
Thank you, Dr. Wiam. We have so many questions, especially for Professor Young. Professor Young, in the era of COVID-19 infection, these attendees are asking, steroids are used now liberally, dexamethasone for 10 days, methylprednisolone and others. Do these pose a risk on, HP axis suppression?
Yes, that's a good question. So remember that 20 milligram 3-week rule. No matter what the dose of glucocorticoid, if it's less than 3 weeks, the HP axis will recover basically immediately. So it's not an issue. So for most of the COVID patients, they're going to be on dexamethasone for less than 3 weeks. Now, if they're on it for more than 3 weeks, and if the equivalent dose is more than 20 milligrams of prednisone for more than 3 weeks, well, yeah, that's a problem. They will be suppressed. And in those patients, we would cut them back to a replacement dose, get them on a hydrocortisone, recheck a cortisol level in the morning before they take their morning dose of hydrocortisone.
Dr. Wiam, you have a question? If not,
yes, I have a question to address to Dr. Ahmed Hassoun. The question is, if a healthy patient with no hypertension had adrenal lesion of less than 1 centimeter only, what is the workup and the follow-up according to the Endocrine Society guidelines?
And I think, as we said, the definition was 1 centimeter and above. I don't know if you can hear me. Yes, okay. But I think smaller things, now we are seeing much more with the advances in technology. So probably things are changing, and maybe Professor Young would probably have more update on this. But basically, is a small one like this, I would look into the clinical features first of the patient, if he has any features of, let's say, Cushing or, adrenal secreting hormones. And if it is a small one, at least I look into that. And if that's there, then I would probably go further steps to investigate. Otherwise, I would not investigate. I don't know about Bill, what you think about that.
How about the follow-up? The follow-up, was it, you'll do it every year?
Yes. If I didn't do it for sure, I'm going to follow up this patient. I would do probably 6 months follow-up with an imaging.
Dr. Bill?
Yeah, so I agree with Ahmed. In that 2007 review, I used 1 centimeter because basically you want to be sure you actually have a true adrenal nodule, and it's not just some thickening of the adrenal limb. But the resolution of CT imaging has improved, right, with every generation of scanner. So yeah, now we're seeing clearly it's a nodule. It's 9 millimeters, it's 8 millimeters, 7 millimeters. So really, as long as you're certain it's a nodule, yeah, it's a nodule. But I don't think we should be doing the whole workup that Ahmed shared with us today if we're just talking about some thickening of an adrenal limb. So it's just a matter of making that distinction so that you as the endocrinologist are comfortable that you actually are working up a patient who has an adrenal nodule.
Thank you. Hussein, you had a question?
Dr. Al-Maliki, we have a few questions as well. The role of measuring ADH in the diagnosis of DI, as well as the use of medications such as non-steroidal anti-inflammatory drugs like indomethacin for the treatment of nephrogenic DI.
Regarding the first question, the ADH or vasopressin, it has no role in routine practice. As you see from my presentation, it has several limitations. As the stability is almost for 24 to 48 hours, and the turnaround time is around from the 7 to 10 days. In addition to that, the reliable SA for the vasopressin is not frequently available. So it is not part of our routine practice. And regarding the other question, non-steroidal anti-inflammatory drug, as you know, this is its work based on the fact it inhibits prostaglandin synthesis in the kidney, which is antagonize the effect of the antidiuretic hormone. So once we give it, it will help to increase the concentration of the antidiuretic hormone with the net effect on the urine output from 25 to 50%. But you have to remember that not all non-steroidal are equally effective. Indomethacin, it appears to have greater effect as compared to others.
Thank you, Dr. Musa. Yeah.
I have a question for Dr. Salem. The question is, a patient had history of craniopharyngioma surgery, and as an adult, he came to you for symptoms of growth hormone deficiency. When you treat, would you worry about any recurrence or any issues related to the previous craniopharyngioma?
If the tumor was resected completely or resected partially and treated with radiation, then there is no concern. There is no risk of increase. We had a couple of patients in our series and other patients. The concern was one in our patient was actually not craniopharyngioma. One patient was with macroprolactinoma, and he was treated medically only, and there was a rise in the prolactin level on growth hormone. However, when we examined, he came from a different institution, but we went back and examined all his prolactin levels. We actually found the direction was rising progressively before. We had to stop him on safety basis anyway. But I think if the patients are resected completely or resected totally or treated for radiation for any tumors, there is no concern about that.
Would you do serial MRIs?
I think the standard of care will continue before, as before. There's not been a specific recommendation for that.
Hussein?
Yeah, I have a few questions for Professor Young. One relates to the regimen that you mentioned. Does it really relate to the underlying etiology of the HPA axis suppression? Say, for example, endogenous versus exogenous, Cushing's syndrome versus treatment for rheumatoid arthritis with prednisone and then tapering off the prednisone. Does it really matter, or that's it? HPA axis suppression is treated the same way?
In my view, HPA axis suppression is HPA axis suppression, whether it's from cortisol from the adrenals or whether it's prednisone, dexamethasone, or some other glucocorticoid given by a physician. They're both feeding back on the hypothalamus and pituitary and suppressing production and secretion of CRH, production and secretion of ACTH.
And the follow-up question on that was, you said that if the patient can't tolerate the withdrawal completely, they could stay forever on hydrocortisone, let's say 10, 15 milligram. Are there any consequences for that behavior?
Yeah, so first let me make it clear, that's not my preference as a physician. My preference is we get them off of exogenous glucocorticoids. The reason I made that point is that, at least in the US, many patients put this responsibility of getting them off glucocorticoids on me as the clinician. And I say, look, you're the one that needs to put up with the glucocorticoid withdrawal symptoms. If you can't, that's okay. Stay on 15 of hydrocortisone or 15 and 5. If they ask me if I think that's wise, I'd say no. That's not wise. That's not what I would do if I was on steroids. I'd put up with the glucocorticoid withdrawal symptoms. So, to answer the question, is 15 milligrams a day harmful? I doubt it. It's a fairly low dose. If it's a single dose in the morning. As you know, we replace our patients without adrenal glands when we think they do pretty well on 15 and 5 or 15 and 10. So I don't think we're hurting these people by keeping them on 15 milligrams every morning. It just wouldn't be my preference.
I have a question for Ahmed. If you have a patient who came to you with adrenal incidentilloma and the house field units the attenuation is very low, but there was no washout done because of the fear of kidney issues to this patient, would you follow only based on the attenuation without the washout? Any discordant, results usually between those two?
Not really, actually. Bill Young is expert on this, and anyone who has a Hounsfield very low, like less than 10, is almost always a benign lesion. And now what to do about it is depend on the case, but it's most likely this is a very benign consideration. So you don't want to do it, the washout.
Thank you. Sam?
It will not add to you more.
Dr. Al-Maliki, a question about pregnancy in a patient with DI on treatment. How should we adjust the dosages?
Usually the desmopressin is safe during pregnancy, and we continue in the same pattern, but at the end of the pregnancy, as the pregnancy is progressed, we have some resistance, so we might need to adjust the dose. There is no uniform. There is special steps we have to follow, but we adjust those as based the patient response. So of course, with the progression of pregnancy, we need to increase the dose, but it should be based on the patient intake and output.
Thank you. A follow-up question about also SIADH following DI, following brain surgery. How do you make that diagnosis?
Usually the sodium abnormality after the pituitary surgery, it can take several forms. Either in one study, around 5% they might present only with hyponatremia. So it's a part of the SIDH, or it can be part of the triphasic phase. This condition should be suspected when the patient starts to have hyponatremia or retained fluid with the water balance in some study up to more than 2 liters.
Question to Salim. Salim, the question is, if you want to start growth hormone in an adult and you think the patient is qualified to do so, would you screen for any malignancies before you do that at all, or you don't? You are muted, Salam.
Yeah, I think you go by your good clinical practice. If there are any features, but you're not, you have to look for them before as part of good clinical practice. But there is no need to take a patient and actually do all scans and endoscopies and so on for them. There's no indication for that. You only go by good clinical practice, and on all the studies that were published, the patients had a full physical examination and basic investigation only. They did not look for any tumor markers or any other examinations.
Hussein?
One of the attendees, Professor Young, is asking that after you have confirmed that cortisol is above 10 following the withholding of the pill the day before, that some advocate now doing the ACTH stim test. I know that you are not fond of that, but what do you say for those who recommend that?
Right. So, and that actually was what was commented on in that commentary that was published with our article in Clinical Endocrinology. And their comment was some clinicians may feel better doing a cort stim once the serum cortisol is above 10 micrograms per deciliter. If somebody wants to do it, I think that's fine. I don't do it. We don't get into any difficulty with the patients. They feel fine. Their axis is recovered. Now, I certainly understand those clinicians who have been relying on concentropin stimulation tests for many years, and if they went to this new approach, they may be a little uncomfortable. And to make them more comfortable to do a cort stim, sure. What is interesting, though, and as I think all you know, concentropin is not available in every country. There are countries that don't have access to concentropin. So in response to this publication of ours, I've gotten quite a bit of feedback from endocrinologists in those countries that don't have access to concentropin. They said, finally, we have a way to get our patients off steroids and monitor them. And yeah, this makes sense. So it really comes down to clinician preference, I think.
Excellent. Thank you very much.
Dr. Ahmad, a kind of the same question in a different way. You have an excellent washout, more than 60, but you have high attenuation, more than 20. What do you do?
This goes as we discussed earlier with the lipid poor adenoma, because the washout is significant, more than 60%. So this goes again with a benign lesion.
Even though the attenuation has a high, yeah.
Yeah, because of, as I mentioned earlier, because this lipid poor will have a higher, even unenhanced, more than 10. And these are the cases that really the washout is really necessary in these cases.
Yes, Dr. Musa, we have questions about, do we need to repeat the water deprivation test in patients with DI in whom the first water deprivation test was questionable, or that's it? Are there situations where you repeat it?
Water deprivation test, of course, we will do it if you want to subclassify it to determine which type. Is it central, nephrogenic, or if you are in doubt, this is primary polydipsia. But in case if there is central and there you could not find any cause and you compare central DI, I don't think that we need to repeat it. I will repeat it if I am still in doubt. Is this partial central DI or primary polydipsia? In this situation, I might repeat.
What about idiopathic DI?
Idiopathic, that means this patient has confirmed DI. So I have to look for the cause. And as you know, this represents the most common, up to 50%. And the autoimmune process accounts for majority of them. So I have to look for the cause here, rather than the confirmation of the diagnosis.
Thank you. I recently saw a patient who has multiple sclerosis and DI. Is there an association?
It could be. I have seen a few cases. two in my clinic. They have the DI. I think because this is both of them autoimmune process, but as a syndrome, I am not aware about anything like this.
Thank you.
Same thing to Dr. Musa. There's a question about the normal MRI with the bright spot seen very nicely in those cases. Would you rule out completely central DI or still do some workup?
Central DI, the MRI will help to to confirm the diagnosis, to look for the underlying cause. But as you know, it is not specific, not sensitive. As you know, the around 20% of normal population, they have absent bright spot. Even those patients with confirmed in one study, confirmed central DI, around one third of them, they have bright spot still present, especially at the early stage. So absent or present, it doesn't exclude or confirm diagnosis 100%.
We have a general question for Professor Young about interference of cortisol measurement by prednisolone or dexamethasone.
Yeah, so that's very assay dependent. For example, the assay we used, which was a competitive protein binding assay about 15 years ago, had a 33% cross-reactivity with prednisone and prednisolone. So it did cause problems for us. Since then, we've switched to tandem mass spec assay, which basically has zero cross-reactivity with synthetic glucocorticoids. So, but this is important, I think, for all endocrinologists to know with their lab that they use. What is the degree of cross-reactivity with exogenous glucocorticoids? Usually it's never like 100%, but it could be as much as 33%, which certainly could impact if patients on 20 or 30 milligrams of prednisone, for example. You could have a very detectable, what appears to be, detectable cortisol, but it's just cross-reactivity.
Thank you. A follow-up question is about the use of nasal sprays that contain steroids and injections of glucocorticoids for back pain, for intra-articular and things like that. Would these pose a risk of HPA axis suppression?
Yeah, so a glucocorticoid is a glucocorticoid applied anywhere in the body, on the skin, in the nose, in the lungs, in a joint. They're all absorbed, right? They're all absorbed. And it just depends on the dosage used, that person's degree of absorption of the glucocorticoid. A very common diagnosis, referral diagnosis in our Pituitary Adrenal Clinic in Rochester is low cortisol. And I teach our endocrine fellows, 95% of these will be exogenous glucocorticoids. And that should be your first question. Where did they get a shot into a hip 2 months ago? The effect of a joint injection can last for up to 3 months. And it suppresses the HPA axis and cortisol is low. The duration's much shorter if it's intramuscular or sub-Q or inhaled or oral. But yeah, it is the most common cause no matter how the glucocorticoid is administered.
Thank you.
Dr. Salim, back to you. Do you always routinely do the quality of life questionnaire before starting growth hormone, and is it reliable?
The quality of life questionnaire, which is actually accepted currently by all endocrinologists, are the AGDA, Adult Growth Hormone Quality of Life. It's available in English and many other languages. I have a version in Arabic that has been being tested, and but I've seen using my own version. Actually, I've seen it improving. If you think, for example, in practice in the United Kingdom, it is important to do an AGDA score before, not important, it's required to do an AGDA score before, and you need to repeat that in 6 months. If there's no improvement in the AGDA score after 6 months, one should consider stopping the growth hormone treatment.
Follow-up
A copy is available to anybody who wants to use it.
Is it patent, Salim?
No, not patent. Free for you.
Okay, just a question again. A meningioma case, and you want to start a growth hormone, and it's a small one, been followed up for years and no growth. Would you be concerned giving growth hormone?
I think that's a very individual case, whereas you need to talk to the neurosurgeon, to the neuroendocrinologist, if you have, who's been looking after the patient. Is there a need for growth hormone treatment in this patient? Is it actually the last point of care that you want to give? I have seen patients who actually need so many other things, much more important than growth hormone treatment. And I actually spoken to the father. I said, you've been coming to this clinic asking for growth hormone for so long. There are so many other things that I should need to attend to in these patients rather than asking for growth hormone. So I think I have to be very careful in these patients.
Thank you.
The questions never end for Professor Young. So we have few questions. One, you mentioned what Dr. Hassoun said about the less than 1 centimeter. If it's an adrenal thickening and not a clear nodule, then that is not an incidentaloma. What is it then? And how do you follow these abnormalities? Do you follow or you don't follow?
Well, for me, adrenal thick, if I see a slightly thick adrenal and it was incidentally discovered and the patient has no signs or symptoms of any endocrine disorder, I don't work it up. Adrenal thickening is incredibly common. All you have to do is start looking at every CT your patient has. I don't work those cases up.
Okay, good. And we have a question that is just, I guess, semantics perhaps. If someone had a cortisol secreting adrenal adenoma and you resect it, and after that they develop, low cortisol, do you classify that as primary or secondary? I vote for secondary. What do you call it?
Yeah. I'm with you. Yeah, because it's secondary and it's temporary, and I make it real clear in my problem title, that so no other clinicians get confused. I frequently use the word temporary. The last thing we want is for these patients to get labeled with permanent adrenal insufficiency. So I say temporary suppression of HPA axis from cortisol secreting adrenal adenoma resected on such and such date. And I'll do the same thing for exogenous use of glucocorticoids. I'll say temporary suppression of HPA axis iatrogenic due to prednisone usage. Because what happens, and it happens all the time in the US, patients get labeled with Addison's disease. They never had Addison's disease, but they carry that diagnosis. And yet you kind of dig through all the records and eventually find out, no, they were given prednisone for a year. And that was what caused their problem.
Interesting. Thank you.
Another question to Dr. Young, actually, same question almost. A patient who had autonomous cortisol secretion and the patient is post-op, do you check for cortisol next day or after? And is the 10 the cutoff also?
Great question. So for patients with primary aldosteronism, we check their aldosterone level the day after surgery. We want to be sure that we've actually cured them and we did the right thing. For patients with pituitary dependent Cushing's, we check cortisol the day after surgery to be sure that we cured them with our pituitary operation. However, for patients with a cortisol secreting adrenal adenoma, we do not routinely check cortisol the day after surgery. Usually there's no question about what the diagnosis is and the completeness of the surgery. So in those patients, we give them a steroid prep for surgery, and the morning after surgery, they're on glucocorticoids. And surgery in Rochester, they're just in the hospital overnight, so they're going home the morning of day 2, and they already have their prescription for prednisone to go home on. So the first cortisol check I do in these patients typically is only once they're on hydrocortisone, single dose in the morning.
So everybody gets replacement.
Yep.
Hussein?
For Dr. Musa, we have a question about in patients who develop DI after head trauma and they have a normal pituitary MRI, is there any chance for remission?
Post-head trauma DI account for about 4 to 26% of the cases. Unfortunately, it is undiagnosed in our practice. And most of the time it is transient and to resolve within 1 week. However, the minority of patients, they might have permanent, especially in group, they have severe head trauma or require long-standing ICU admission, or they have significant damage to the hypothalamus.
Thank you.
But most of the time it is transient and it will resolve.
Thank you.
To Musa, also, there's a question about your thought on hypertonic stimulated Kubeptem testing in real-life practice.
The Kubeptem, the literature is and the current data is promising. It is a good test, and the patient with a permanent DI is a good test, and it has a lot of advantage in terms of stability and the turnaround time within a few hours, and the accuracy of the assay. But unfortunately, it is not available. I did this in only 2 patients as a send-out test. So if it is available, of course, it will help us and it will make the story short in terms of the diagnosis. And as you can see from my presentation, as the baseline without prior testing, if it is more than 30 or more than, in some study, more than 21, this is the confirmed diagnosis of the nephrogenic DI. But if it is less than 2.5, this is going with the central DI. However, if it is in between, you have to do the dehydration test, and the ability to differentiate between primary polydipsia and central DI is very high in this situation. So if it is available, of course, it will be a good test. But in the post-op Kubeptem measurement, it is not recommended yet for several reasons. Availability, as I said. The other issue regarding the optimal time for testing. Some study they found if you do it within 12 hours, you will have good results. But with time, the sensitivity, or the accuracy will be less.
So this is using hypertonic saline for a Kubeptem.
Kubeptem, there are 2 methods. Either you give the start dehydration, this one method. Other one is you give hypertonic saline. Both of them validated, and they found the hypertonic has more superiorities, more diagnostic accuracy than the water deprivation test.
Thank you. We have 5 minutes more.
Yeah, Dr. Young, do you prefer prednisone over hydrocortisone for patients with permanent AI who need glucocorticoids?
Actually, no. If a patient has permanent adrenal insufficiency, we've shown that prednisone has marked inter-individual variation in biologic activity. In other words, we've seen iatrogenic Cushing syndrome in patients treated with just 5 milligrams of prednisone every morning. So if possible, I personally like to use hydrocortisone. There's less inter-individual variation in terms of biologic availability, and the correct dose is the lowest dose that the patient feels well on. There is no lab test that guides you. This is not like giving thyroid hormone and measuring TSH. So it's the lowest dose the patient feels well on, and the highest dose would be 20 and 10. I mean, that used to be the old standard dose, but these days we're trying to get the patients the lowest dose that they feel well on, and it might be 15 and 5, might be 10 and 5. Usually we wouldn't go below 10 and 5, or it might be 15 and 10.
Do you like the triphasic hydrocortisone?
Oh, I wish I had it. We don't have access to it yet. I have some European patients that are on it, and it seems to work reasonably well. But I have no personal experience beyond that.
Thank you.
Question to Ahmed Hassoun. Is there any role for a PET scan in looking at adrenal incidentinomas?
For sure, there are some, as we mentioned earlier, comparing the people who have less likely to be malignant and benign, they have, PET scan. If they did for them, they will see there is more avidity for malignancy. So it has some role, but it's not like the main thing to start with. You can use it in some cases that you are not sure about it. You need some more evidence to help you, or in cancer cases, it would be something to help you. Yes, it has a role. It's not in the immediate, workup of the patient.
I have a question to Dr. Salem. Athletes who use growth hormone, we see it a lot, unfortunately, in this part of the world, and they use it for a long time. After stopping it, would they have the symptoms of growth hormone deficiency? Do you do anything specific, or you do the same workup for them?
I think the indications of the legal indications for growth hormone are very clear. Growth hormone deficiency in children, growth hormone deficiency in adults, and AIDS-associated weight loss and all the deficiency of muscles and so the wasting that happens with the AIDS syndrome. And experts in AIDS, they say they are not seeing this more now. All other uses for growth hormone are illegal. If somebody comes to me to the clinic and mention that actually they want this, I say, I'm sorry, I don't give that. I'll tell them it's illegal and there's no benefit from it. The problem actually that they get from the gym trainers growth hormone with other things that work on them, which is they give them high dose of testosterone. Also, the doses they use, although there's nothing in the medical literature about that in full detail because it's all black market, they give higher doses. But I wouldn't treat them for that because it's not something that actually suppressible. So I won't treat them for that. I will educate them and tell them stop using it. It's of no value, more side effects than benefits.
I think I'm done with the questions here for Professor Young and Dr. Al-Maliki. Thank you very much for answering all these questions.
I have one last question here. It's for Dr. Young. The question is about the old way of tapering the steroids, giving it alternate days. You did not mention that in your practice. Yeah,
that's a good point. We really haven't used that. That falls more into the realm of rheumatology. They tend to do that because they're trying to get patients on a lower dose and they still want to treat their rheumatologic disorder. But when we're trying to taper for recovery of the HPA axis, we find a short-acting glucocorticoid every morning works very well. Now, could there be an alternate way of doing it every other day? Absolutely. What I've shared with you today is one approach. I'm sure there are another 15 approaches that could be just as good, but I know this one works, and that's what I wanted to share today.
Thank you. Thank you very much. At the end, I'd like to thank all of you. I'd like to thank Dr. William Young from Rochester, Minnesota, Dr. Ahmed Hassoun from Dubai, Dr. Salem Bishir from Abu Dhabi, and Dr. Musa from Riyadh, and Dr. Hussein Saadi from Abu Dhabi for co-chairing. It was a very nice session. We had lots of time for questions, which is, I think most people enjoyed it. I thank you. Inshallah, we'll see you next year.